So now I'd like to invite all of the speakers who were in this section. In addition, Dr. Craig Dobson, our Director of Clinical Operations, will be joining us on the stage for a panel discussion. We've got quite a few questions in the chat. So if you could pop up maybe, I'm hoping, is Joan, are you still able to hear us?
Yes, and the camera is working.
Great, fantastic. So while people are assembling here, I'm going to put you in the hot seat. We had a question regarding kind of how you guide your decisions of how to and which inotropes you may or may not use when you're trying to treat low cardiac output syndrome in neonates with Ebstein's. And then sub-question, do you use any imaging parameters to guide your decisions?
Well, this is an important question. And if you notice, I didn't want to go specifically on which ones to use because there is as many choices as cooks exist in this world. So I think that it's about physiology and understanding what the problem is, understanding what are the side and the collateral effects of each inotrope and what we want to achieve. So we want to achieve pulmonary flow. We want to decrease pulmonary vascular resistance. So ideally, milrinone would give us inotropy and lusotropy and vasodilatory effect. And for inotropy effect supporting the left cardiac output, we typically use a little bit of epinephrine. I want to reinforce the fact that the most important thing is to promote venous return, but not to increase volume overload. So those drugs that will favor pulmonary venous return without increasing pulmonary vascular resistance are especially indicated in those patients. So for instance, vasopressin, which will give us vasoconstriction, venous constriction, and will decrease PVR. So again, there's no one single choice. You have to stick with what you have and get back to the physiology.
Yeah, absolutely. Thank you for that really thoughtful answer. So next, we have a question from the chat regarding when you have assessed a severe circular shunt and the team has made the decision to stop prostaglandin to restrict the ductus. This person asked, do we care about anterior flow in the case of functional pulmonary atresia or pulmonary stenosis? Maybe you could talk about pulmonary development and if this is a consideration. The downsides of stopping PGE in this case. I don't know if Dr. Knott-Craig wants to comment on.
So, can I answer the previous question first?
Yeah, sure.
So my go-to drugs after neonatal Epstein repair is medical volume resuscitation, which is a synonym for vasopressin. It achieves exactly the same thing. And so I agree with the intensivist. So low-dose epinephrine, 0.03 max, associated with vasopressin. I think those are your go-to drugs in the neonatal Epstein patient. And then in terms of stopping prostaglandins, I think it's got to be done in a controlled situation. The patient's got to be in a cardiovascular intensive care unit.
Yeah.
And then you need to clearly state what your threshold is to restart the prostaglandins. And for someone who's on positive pressure ventilation, in our experience, that would be 78%. Saturations are better than 78%. You can assist with stopping the prostaglandins and looking and seeing how the ductus closes and whether there's initiation of prograde pulmonary blood flow.
Great, thank you. So another question that's come up. So now this is a question for Dr. De Silva or Dr. Knott-Craig. In a patient where you are placing a bidirectional Glenn with this physiology, how important is pulmonary regurgitation, and what, if anything, are you doing to address pulmonary regurgitation at the time?
Yes. Well, we had bad experience in two cases, actually. One came from outside, because people use a Glenn procedure and then dilated the ventricle and after the cone. The cone procedure was very nice, but despite of that, the heart was still dilating progressively. And that was because of pulmonary regurg. That was become more severe because of dilation of the outflow tract and functional regurgitation. So if you have pulmonary regurgitation, it's better, except if you have a small ventricle, of course, in hypertrophy, small ventricle in general, is well functioning, you have to take good care of the pulmonary regurgitation. Otherwise, you have some risk of the gland does not work well because you have more regurgitation diastole because the blood is flowing in the gland in systole and diastole. So that may overload the RV a little more, get a higher pressure and diastolic pressure for the RV. So I recommend to take care of the pulmonary valve too at the time of doing the Glenn.
At the time. Thank you. There's a question I'll ask several of you to weigh in on. This is a good question. So the question is, are there any parameters that would deem biventricular conversion with a De Silva cone procedure prohibitive or high risk? And then I'll also put out there, are there features that you like to see as well? And these could be imaging features or clinical features.
So some centers, they are considering the velocity in the stance orifice to indicate or not the conversion to biventricular repair. And our experience that the velocity makes no sense to contraindicate the procedure because the filling of the heart is not enough. And we are doing the cone in all patients, even if we have a low pressure in the right ventricle. So that's one of the question, one of the issues that we are seeing in other presentations. Another thing is the function of the right ventricle. Sometimes it's very difficult to evaluate. Then we need to go back in the pre-stance function of the ventricle. We can evaluate the anatomy of the valve and the function of the ventricle itself before the stance to see, have an idea what we can expect about the function of the right ventricle. We had two patients that they had severe RV dysfunction in the post-op, and those patients, they had a velocity in the stance less than 1.5 meters per second. So we don't have still a huge number of patients to say that would be predictive of bad RV function in the post-operative period. But all those patients, even with bad ventricular function, they have a low pulmonary venous central pressure. So that will be more beneficial than a Fontan procedure in the long term, we imagine.
Well, those are outstanding points. Sorry, go ahead.
Go ahead. I'll make one after you. Go ahead.
No, I want to clarify a question first, but I can do it after him.
So actually, I was just going to say that from the sort of clinical and imaging standpoint, I think the appearance of, when you look at a post-Starnes right ventricle, can frighten you off of the possibility of rehabilitating the ventricle. You certainly alluded to that, and we brought that up in the paper that we wrote. But all of us, I remember sitting in surgical conference going, one particular, that's not a very good one. We don't think we can do it. And several of us felt that way. I certainly said, I don't think this is a good idea. And you said, I want to try. And so that patient, I was on the ward as the attending the next day after that patient's procedure, and the toddler came bouncing up to the ward a day after a successful cone after Starnes, and I was floored. These patients, I think from an imaging standpoint, sometimes looking at an underfilled right ventricle that may not be squeezing, but may not be squeezing because it's not getting enough flow, it can be very daunting to realize that this actually is possible.
Oh, that's a great point. Go ahead.
Yes, I agree that in general there is some concern about that, but as we discussed, it's not possible to define it. I'm more concerned when the heart is dilated. Because if the heart is small, then you put more volume there, and the amount of volume of ejection is not, the blood ejected to the lung could be a little low, but then you have the chance to have a glen or even a shunt if you have a case of elevated pulmonary vascular resistance, contraindicating a shunt. So we don't know for sure. And since we're at the beginning and you have a way out of it, which is getting new source for the blood, the lung perfusion, and wait for the heart to recover, I think that's why I think we can invest in that, and then we find out what was the best way to evaluate it preoperatively. But I want to take the opportunity to make a comment about Chris' presentation. We have been friends for a long time, but I didn't know his work as deep as he shows today. And I know that he has an excellent result with his primary repair, and we get the benefit of two ventricle repair from the beginning. But now the other, so is one thing. The other is that we have a rare disease. Many people never operate an Abbott anomaly, never repaired. And when a newborn is decompensated in heart failure, is far away from the center, like here or his center, then we have a different problem. So nowadays, we are discussing that issue at the ATS group, writing group, and part of that, Dr. Knott-Craig also part of that. So some of those issues are going to be resolved, but the tendency is to indicate in those difficult cases the Starn procedure, because I think it's easier to be done. And especially if you consider the case of pulmonary atresia, true pulmonary atresia, with no leaflet, there's just muscle or fibrous tissues. So in that case, I think it's much simpler to do the Starn for any surgeon that have a good experience doing congenital heart surgery. On the other hand, we cannot, the surgeon can do it well, primary repair, like we do with the cone in special condition, like he does in most of his cases. So they have to pursue that path too, and then at the end we can compare with larger numbers. Regarding doing this, the repair after the Starn, repair the trachea valve, we were the first to bring up, to do it, but the concept was demonstrated by Dr. Craig when he replaced the trachea valve by a bioprosthesis in the patient who had the Starn before. So there are different things, but he proved that was possible to do. So he was the first to do that. I recognize it in my initial paper, even though I've been provoked because I didn't see that paper. I saw the paper, but the case was embedded in other cases, and I didn't see that. Maybe I had thought I had done it much earlier, the repair trachea after the Starn procedure. So I want to clarify that and say that his work is really excellent. I saw the repair he did. It's like a a master doing an operation. And I think that can be performed in some patients because it's easier. And by our experience too is very good. We never had an issue with abstinentally repair. All the patients survived.
Yeah.
Now with the technology that we have available. In Brazil, when we did primary repair, we had good results, but they were kind of selected patients, a little older, after 15 days of age, between 15 days and 30 days. We did the total of, when I was there, 10 cases. We lost 2 patients, and one of them was because of pulmonary bleeding. So it's not directly related to the operation, but because of AVMs. And the other one for heart failure, and we didn't have the option of ECMO at that time. So those
Means the primary con repair,
the
neonatal
primary
Epstein.
repair, right?
Yeah.
But I understand that is possible if you have a lot of experience. If you want to do it in general, then I think the standard procedure makes more sense.
Yeah. No, your comments are so appreciated, and it's such an important point. And I was really inspired watching your pictures of all your patients, as well as the pictures of the intraoperative videos. I think it's just remarkable work, and it's great to have you both on the same stage to discuss your separate, slightly different, but also more similar than different perspectives, I think, on young babies with this condition. So I think that's great. Dr. Knott-Craig, did you have any comments regarding that?
South Africans, once you get them talking, you can't get them to shut up,
Okay, well, we do have a timer, sir.
Dr. Silverman is a good example of that.
Okay, do you have one comment then?
I have one comment. The problem with the neonatal Epstein is that it's become fashionable to talk about the RVSP, or the right ventricular systolic pressure. But when the tricuspid valve is hugely dilated and there's absolutely no coaptation, the RV can't generate any pressure. So I think in my own experience, I don't look at the RV systolic pressure based on the tricuspid regurg. I just look at the RV function. If there's a reasonable right ventricle and a reasonable right ventricular function, I really think that those patients could be easily repaired in the neonatal period.
And that's a great comment and a great segue to our next question. And this is more for Dr. Christopher. When you think about RV size and RV function in the quote inner stage, how are you as an imager assessing these things? What tools are you using? What are you relying on? Echo, MR, et cetera?
That's a good question. And I think, as I alluded to, we don't have all the answers. And so that's one of the great benefits in having all these referrals, so that we can really, gain numbers and knowledge about what parameters make the most difference here. I think, in summary, really taking multiple modalities and multiple measures into account is probably the most important. There isn't just one particular that, as we've heard, makes a patient not a candidate or a great candidate. But I think in specific to function analysis, certainly the cardiac MRI, I think, as Dr. Al-Said discussed, is our best, kind of most accurate quantitative measure of that. And so that has become our standard for preoperative candidacy.
Oh, that's great. And I think something I've always, working with you both, working with all of you up here, something that's been impressive to me is how much, Luciana and José, you asked to go back to the fetal images to understand the valve tissue and what the heart looked like in development. That's been really impressive to me. And Dr. Weinberg gave a great talk earlier today about that, but I didn't know if you wanted to comment about just the relative importance of the fetal and the early neonatal imaging in some of the decision to do cone after Starnes.
Yes, so every time that we are evaluating a patient for a cone after Starnes, we ask for the operative report, the previous one, when the patient's coming from outside, and the pre-Starnes images. one of the patients that we received, he did not have one because he was taken from the belly of the mom immediately to the operating room to do the stars in another center. So we asked for the fetal echo, and that fetal echo gave us the image that we need, and the valve looked like a little bit muscularized. And at the surgery, we found that was truly like more muscle than leaflets in some place of the valve, and we were still able to do the cone repair. So all the patients that we received to evaluate after the stents, we were able to fix the valve until now. I would call attention for some patients that are waiting for a long time, and then they develop systemic pulmonary collaterals, and that make a little bit more difficult the operation itself, because we receive a lot of blood come in the left ventricle. That makes really difficult the operation. So those are the points that we really look for. And I like the idea of Dr. Knott-Craig in some patients to place the prosthesis in the tricuspid position if the valve is very difficult to repair, but place the prosthesis there, but keeping the leaflets, especially in those newborns with a normal pulmonary valve, with a functional pulmonary atresia or normal pulmonary valve. So those patients can benefit from that technique. We did 3 cases of cone after tricuspid valve prosthesis, and the patient did really well. So this is another thing that we need to warn the surgeons. If they are doing a repair in the tricuspid valve, they are not able to fix the valve, please do not remove the leaflets. Keep the leaflets there. Make sure that they will not be obstructing the valve. Place a prosthesis, and later on, when the patient needs, we can try to fix the valve. And if you are biventricular repair, the neonatal in 2020, she had a prosthesis and the leaflets are there, we can fix that too.
That's great. No, it's such an important message. Thank you, Luciana. That's great. One last question for the panel. We talked a little bit about, some of you touched a little bit about this in your talks about kind of the early age for when you would attempt a cone. We have a couple questions in the chat about how late might it be to do a cone. So cone at the time of a long time gland, maybe before a Fontan, when clearly the RV has, remodeled and adapted to having a Starnes patch in for a long time. Is this something you've thought about, or something that you can offer some insight into?
During the presentation this morning, Sarah Trucco called attention about the indication for ASD closure. I think those patients, if we have an indication for ASD closure, they need to come to the OR to do the repair, like she mentioned before. And the reason for that is if we operate the patient at early age, during the growing process, there is a possibility that the growing process with the tricuspid valve in the right position, with the ventricle pumping against with a competent tricuspid valve, it can have a better function in the late term. But this is something that we still need to evaluate. And some patients with the tricuspid valve, I abstain anomaly, they are feeling like well, but they cannot imagine how better they could be if they had the valve fixed. So it's a little bit tricky to evaluate the symptoms in patients with Ebstein's anomaly. And some of the adult patients that we operate here around 40 years of age, after the operation, one of the ladies told us, oh, if I know that was the real life, I would have operated much earlier. So this is something that we need to take in mind, and with the possibility to do the cone repair in almost 100% in our experience. We had just one patient that we need to replace the valve after the cone here. So I think we should indicate earlier, around 4 to 5 years of age, not to wait too long in those patients that has severe regurgitation and dilated heart mainly.
Yeah, please, do you have a final
Do you
comment?
want to know specifically about the cone after Starnes?
Yeah, that was part of the question, was
Okay,
cone after
yes.
Starnes, like how,
Yeah.
what's the,
Yeah, that's
no,
difficult.
that was a great answer. Yeah, we could talk all day.
Right. That's a difficult question to answer right now, but for example, if you have a patient that's not doing so well with the fontaine, and you have to take down the fontaine, then there's a procedure that people, that we do it, not often, but we do it sometimes. And then if you have RV, that can be recovered with the pulmonary valve, for example, or tricuspid valve, then we can do a bed 1.5 ventricle with a fenestration. So then we give time for the RV to recover, and at the beginning, we'll supply some blood to the lung. And you can even add a little shunt. You have already the gland. So, but we don't have experience to say that yet, but I think it's possible.
Yeah, something to look forward to. And Luciana, your answer was fantastic. It was a kind of a two-part question. So thank you very much. I think we're out of time. Thank you so much to our panel of speakers. This was a fantastic discussion.